In this video, we are going to discuss anti-thyroid drugs. For understanding anti-thyroid drugs, first we should study the histology of thyroid gland. We know the functional unit of thyroid gland is follicle because within the follicle only thyroid hormone get synthesized and stored. So the thyroid follicle are called as functional unit of thyroid gland. But you should also note down one more point. In between the follicle, there are some small cells. These cells are called as parafollicular cells. The parafollicular cells causing a release of calcitonin. Calcitonin, a tumor marker for medullary carcinoma of thyroid. Now, look at all these are follicle. Within the follicle only, thyroid hormone synthesis occur. For understanding anti-thyroid drugs mechanism action, first we should study physiology of synthesis of T3 and T4. For discussing synthesis of thyroid hormone, I just take one follicle and I'll explain the physiology of synthesis. There are so many steps involved in synthesis of T3, T4. Step by step I am going to explain. First step is iodide uptake. There is one transporter called sodium iodide transporter. Through the transporter, first step is iodide taken into the follicle. Once the iodide come into follicle, within the follicle we have one enzyme called peroxidase enzyme. With the help of peroxidase enzyme, iodide converted into iodine. The next step is within the follicle there is one thing called thyroglobulin called tyrosine residue. Now this iodine going to join with the tyrosine. The joining of iodine with the tyrosine is called as organification. Here one important point, if the iodine going to join on one position of tyrosine, they form monoiodotyrosine. Suppose the iodine going to join on two positions in tyrosine mean they are going to form diiodothyronine. So the next step is organification, thereby formation of monoiodotyrosine and diiodotyrosine. After formation of monoiodotyrosine and diiodotyrosine, the next step is coupling. That is monoiodotyrosine coupled, that is combining with the diiodotyrosine resulting in formation of T3, that is called triiodothyronine. And sometimes the diiodotyrosine can combine with the another diiodotyrosine resulting in the formation of T4. That means by coupling of monoiodotyrosine with the diiodotyrosine we get T3, and coupling of diiodotyrosine with another diiodotyrosine resulting in formation of T4. It is called synthesis of T3 and T4 hormone. Once the thyroid hormone gets synthesized, it gets stored in the follicle. This point is very important. One of the beauty of thyroid gland is they are going to synthesize the hormone and they are going to store the hormone for about 3 to 4 weeks. They are getting stored here. After storing for about 3 to 4 weeks, and then only there is a release of T3 and T4 occur. Once the T3, T4 get released, they goes to circulation. In the circulation, the T4 by removal of one iodine become T3. The T3 is the most active form of thyroid hormone. So all these steps explain the synthesis, storage and release of thyroid hormone. If we know the physiology very well, my topic of anti-thyroid drug is easy. So to reinforce the knowledge, just to reinforce your memory, I am just explaining the same thing in a diagrammatic format. Come on, one by one. The first step involved in synthesis of third hormone is iodide uptake. So all of you just look at, imagine it is a thyroid follicle. The first step is iodide uptake. Once iodide comes into the follicle, the iodide become iodine with the help of peroxidase enzyme. Once the iodine get formed, it going to join with the tyrosine. That is called organification. They may form monoiodotyrosine and diiodotyrosine. Once they get formed, next step is coupling. Coupling of mono with the diiodo and coupling of diiodo with another diiodo, resulting in the formation of T3, T4 hormone. Once the hormone gets synthesized, it gets stored here, stored for about 3 to 4 weeks, and then the hormone getting released. This is, imagine, peripheral circulation. So both T3 and T4 both are getting released into circulation. In the circulation, the T4 mean containing 4 iodine. This T4 by removal of one iodine become T3. The T3 is the most active form of third hormone. This iodine may again going for uptake and further synthesis of T3, T4 happening. This indicate synthesis, storage and release of T3, T4. After understanding this, we now go for discussion of antithyroid drugs. The first group of antithyroid drug what we going to discuss is thioamides. First of all, we should know what are all the examples for thioamides. Thioamides examples are carbimazole, methimazole and propyl thiouracil. Now we are going to study mechanism action of all these three drugs. All these drugs are inhibiting synthesis of thyroid hormone. How they inhibit? Point 1. They inhibit various steps involved in synthesis of T3, T4. That means inhibiting iodide oxidation. That means they inhibiting peroxidase enzyme. And second, they also inhibit organification, that is, inhibiting the formation of monoiodotyrosine and diiodotyrosine. Third level, they also inhibiting coupling of monoiodotyrosine with the diiodotyrosine. That means three steps, doctor: inhibiting oxidation, inhibiting organification, and also inhibiting coupling. By the three important mechanisms, ultimately they are going to inhibit synthesis of T3 and T4 hormone. That's the mechanism action. Here, all these three drugs are inhibiting the formation of new thyroid hormone. But you should know the thyroid follicle having the capacity of storing their hormone for 3 to 4 weeks. That means these drugs are inhibiting new hormone formation. But already there are some hormone in the follicle. So until they get depleted, these drugs do not produce their clinical manifestation. That means these drugs needs at least 3 to 4 weeks for the benefit to occur. That means there's a lag period of minimum of 3 weeks, 1 to 3 weeks I put, but usually it takes about 3 to 4 weeks for the benefit to occur. That's one important point. But here you should know the propyl thiouracil, in addition to inhibiting synthesis of T3, T4, it has one more property. That property is inhibiting peripheral conversion of T4 to T3. We all know T3 is the most active form of thyroid hormone. So, propyl thiouracil not only inhibiting synthesis of T3, T4, but also inhibiting peripheral conversion of T4 to T3. That means Among these three drugs, propyl thiouracil having dual mechanism action. That's why for the treatment of severe thyrotoxicosis and for the treatment of thyroid storm to have a rapid benefit, the best drug of choice is propyl thiouracil. I put PTU. PTU means propyl thiouracil. So what we done is thioamides are acting by inhibiting synthesis of T3, T4. In that, propyl thiouracil has one more action, that is inhibiting conversion of T4 to T3. Now some small information about individual drug. Among the thioamide, carbimazole is a prodrug. The active form of carbimazole is methimazole. Methimazole. And once again, when I compare methimazole with propyl thiouracil, methimazole having longer half-life, say 4 to 6 hours, whereas propyl thiouracil is having very short half-life, say 1 to 2 hours. That is one point. Second point, propyl thiouracil having very strong plasma protein binding capacity. Because of having very strong plasma protein binding capacity, propyl thiouracil less chance of crossing placental barrier. So comparing to methimazole, propyl thiouracil having more plasma protein binding capacity, so less chance of crossing placental barrier. All these are some minor difference between methimazole and propyl thiouracil. Now we are going to study adverse drug reactions of thioamides. The most common adverse effect of thioamide, that is methimazole or carbimazole or propyl thiouracil, whatever it, the most common side effect of thiamide is maculopapular skin rashes, urticarial skin rashes, itching, sometimes skin discoloration. So to control the itching, we have to give antihistamine. Sometimes we have to go for giving steroid also. So remember, the most common, I put MC, that means the most common side effect of thiamide is maculopapular skin rashes. But the most serious adverse effect of thiamide is agranulocytosis. Remember, this is very important. The most serious side effect, serious, most serious problem is agranulocytosis. That's why if a patient is on thiamide complaining of sore throat or recurrent fever, think of agranulocytosis, estimate the blood count. So one of the most serious adverse effect of thiamide is agranulocytosis. Then propyl thiouracil having some unique problem, in the sense propyl thiouracil causing severe hepatotoxicity. So among the thioamide, propyl thiouracil having strong hepatotoxic problem, and sometimes they also cause SLE problem, vasculitis problem. So in addition to agranulocytosis, propyl thiouracil causes more of hepatotoxicity. But one another point, all thioamides are unsafe in pregnancy. That means for treating hyperthyroidism in pregnancy, all thioamides are unsafe because all are teratogen. They causing what type of fetal problem? Look at one of the important problem, the baby born with aplastic cutis. That means look at the scalp. There is a defect in the scalp. It's called aplastic cutis. Another problem, the baby may be born with choanal atresia. Choanal atresia. That means the teratogenic problem of thiamide is causing aplastic cutis and choanal atresia. That means my next question, which is the safer antithyroid drug for treating pregnancy hyperthyroidism? See, among the thioamide, propyl thiouracil having very strong plasma protein binding capacity. so less chance of crossing placenta. So in first trimester of pregnancy, for treating hyperthyroidism in pregnancy, the best drug of choice is propyl thiouracil. I am repeating, the drug of choice for treating hyperthyroidism in first trimester pregnancy go for propyl thiouracil. So comparing to methimazole, propyl thyroxine having less chance of crossing placenta. But in the second trimester, third trimester, baby liver get developed and liver organogenesis and development occur. So we know propyl thyroxine is strongly hepatotoxic. So we cannot continue propyl thyroxine throughout the pregnancy. So it is better to go for from the second trimester go for methimazole. So for treating hyperthyroidism in second trimester and third trimester, best option methimazole. So this is very important MCQ question. I am repeating, for treating hyperthyroidism in pregnancy in first trimester, better choice will be propyl thiouracil, whereas in second trimester and third trimester, better option may be methimazole. That finishes important mechanism action of thioamide and their uses and the important adverse drug reaction. That finishes thioamides. The next important antithyroid drug what we are going to study is Lugol's iodine. Lugol's iodine actually a combination of 5% iodine and 10% of potassium iodide. What is the mechanism action of Lugol's iodine? This drug going to inhibit the release of T3, T4 from the thyroid follicle. That means inhibiting release. Because of inhibiting release of T3, T4, it rapidly controlling the symptoms of hyperthyroidism. That means the fastest acting antithyroid drug is Lugol's iodine. This is again old important question. The fastest acting antithyroid drug is Lugol's iodine. That's why this drug very useful for immediate control of symptoms of thyrotoxic crisis. Remember doctor, for treating thyrotoxic crisis and for thyroid storm, we have to use combination of propyl thiouracil with Lugol's iodine. I told already propyl thiouracil having dual mechanism action, inhibiting synthesis of T3 T4 as well as inhibiting peripheral conversion of T4 to T3. So for hyperthyroid emergency, for rapid control of symptom, the best combination is propyl thiouracil plus Lugol's iodine. And the Lugol's iodine having some more advantages in the sense reducing the vascularity of the thyroid gland, making more firm in nature of thyroid gland. All these property very useful for pre-operative preparation of thyroid gland, thereby reducing bleeding while operation. So one of the advantage of Lugol's iodine useful for pre-operative preparation. What are the important adverse effects of local sodium? It may cause mostly allergic reaction. Sometimes may cause dangerously angioedema. That's one important point. Second point, it may also going to cause exacerbation of acneiform skin rashes. And when you give prolonged period of Lugol's iodine therapy, it may cause one side effect called iodism. Iodism, where the patient having too much of lacrimation, salivation, rhinorrhea, sometimes breathing difficulty, all sometimes headache, all are important symptoms of iodism. Anyway, repeating the important adverse effect of Lugol's iodine, angioedema, sometimes exacerbation of acne from skin rashes, and also risk of iodism characterized by headache, rhinorrhea, salivation, and sweating, all these things. The next important group of anti-thyroid drug, what we're going to discuss is, we have some drug called potassium perchlorate, thiocyanate, and fluvoborate. All these drugs, how they works? These drugs are inhibiting the uptake of iodine. The first step, iodine uptake, no, that is blocked by potassium perchlorate and thiocyanate. But these drugs are not used in practice routinely because all are dangerous. For example, potassium perchlorate causing side effect of severe aplastic anemia and also causing severe gastric ulcer. Thiocyanate may cause side effect of psychosis. So all these drugs are causing more side effect, so they are not routinely used. In this junction, you should know one important point. We have one drug called sodium nitroprusside. We know sodium nitroprusside is a vasodilator useful for treatment of hypertensive emergency. Here you should know sodium nitroprusside containing cyanide. Cyanide. The cyanide in the body may be converted into thiocyanate. Thiocyanate. Usually, thiocyanate will be getting excreted through kidney within 1 to 3 days. But when you give nitroprusside prolonged period, say when you give more than 24 hours, or if you give this drug in a renal failure patient, there may be too much of accumulation of thiocyanate that may inhibit uptake of iodine, thereby risk of hypothyroidism. That means you should know sodium nitroprusside having the risk of causing hypothyroidism problem. The next important drug useful for hyperthyroidism is radioactive iodine. Here I go point by point. First point, which is the radioactive iodine useful for treatment of hyperthyroidism? The answer is iodine 131. First MC question. The half-life of iodine 131 is about 8 days. Second important point, the iodine 131 emitting two rays. One is called gamma ray, one more thing called beta ray. The emission, the, the power of penetration of this radiation is 0.5 to 2 millimeter. Here important MCQ, among the beta and gamma ray, remember gamma ray useful for diagnostic purpose, that is thyroid scanning. Beta rays useful for treatment purpose. Remember, beta rays are useful for treatment purpose. Now, what are all the indications to start radioactive iodine 131? Point 1. Iodine 131 useful for treatment of hyperthyroidism, especially in a older patient and in patient with heart disease. That means wherever other drugs are not able to use, in that case we can try the last option, iodine 131. And iodine 131 also useful for treatment of thyroid cancer. And because of emitting gamma ray, it can also useful for diagnostic purpose called thyroid scanning. So remember, useful for treatment of hyperthyroidism and treatment of thyroid cancer, as well as useful for diagnostic purpose. What are the important adverse effects of iodine 131? The most important problem, the iodine 131 destroy the follicle completely. That means they're going to cause permanent hypothyroidism. This is one important MCQ. One of the most important problem, they causes permanent hypothyroidism. Other problems are, there is a risk of causing breast cancer, kidney cancer, stomach cancer. So risk of causing cancer, stomach, kidney and breast. And one more problem, the radioactive iodine may cause thyroiditis, radiation induced thyroiditis. Because of causing thyroiditis, there may be chance of release of T3, T4 from the follicle that may cause secondary hyperthyroidism. So to prevent this complication, before giving iodine 131, better you start thioamide to control the hyperthyroid problem. So it's a rare problem, but you should know this problem. Anyway, the most important problem, permanent hypothyroidism. Second question, what are all the organ may develop cancer due to radioactive iodine? Think of cancer breast, cancer kidney and cancer stomach. And then iodine 131 should not be used in which condition? For example, the most important contraindication in pregnancy for treating hyperthyroidism in pregnancy and in young children and in lactation. And one more thing, in a Graves' disease with eye problem, ophthalmopathy. In these three conditions, don't use iodine 131. Look here, iodine 131 is the teratogen. So in pregnancy for treating hyperthyroidism, don't use radioactive iodine. In young children, where we can use other drug, whenever other drugs are not able to use, mean in that only we can use radioactive iodine. And one of the adverse effect of radioactive iodine, they are going to aggravate the eye problems in Graves' disease. So, in ophthalmopathy case also, iodine 131 contraindication. And then we know iodine 131 useful for treatment of thyroid cancer. Here, they useful for follicular cancer. Iodine 131 taken up by the thyroid follicle, so used only for follicular cancer. The iodine 131 is not taken by parafollicle. The cancer arises from parafollicular cell is medullary cancer of thyroid. So iodine 131 cannot be used for treatment of medullary cancer of thyroid because medullary cancer originates from parafollicular cell. Parafollicle do not pick up iodine 131. That means they take a message iodine 131 useful mainly for follicular cancer. Here I want to tell two important points. For treating medullary cancer of thyroid, we have some newer tyrosine kinase inhibitor like vandatanib and cabozantinib. All these are tyrosine kinase inhibitor useful for medullary cancer thyroid. Whereas we have some more newer drug like lenvatinib and one more drug sorafenib. All these are tyrosine kinase inhibitor useful for well differentiated thyroid cancer. That means useful for follicular cancer. That means they take a message for treating thyroid cancer and for treating parafollicular cancer. We have some newer tyrosine kinase inhibitor. So important new information. Please read repeatedly. Then there are some drugs going to inhibit peripheral conversion of T4 to T3. That is done by so many drugs like beta blocker, mainly propranolol, very important, propranolol, and then amiodarone, propyl thiouracil, steroid like dexamethasone, and one more drug IPO, ipodate. All these drugs are able to inhibit peripheral conversion of T4 to T3. Here one physiology you should know. Peripherally in the circulation, T4 converted into T3 by removal of one iodine. The removal of iodine done by an enzyme called 5-deiodinase. That means all these drugs are having the ability of inhibiting 5-deiodinase, thereby inhibiting peripheral conversion of T4 to T3. Here I go some extra point that propranolol, a important beta blocker having antithyroidal activity by two ways. One way, inhibiting peripheral conversion of T4 T3. The second way, the beta blocker controlling symptoms of hyperthyroidism like tremor, palpitation. So, in a case of thyroid storm, to control symptoms of palpitation, tremor, we have to supplement propranolol. And then very important question, propyl thiouracil is a thioamide. The only one thioamide having dual mechanism action is propyl thiouracil. That means inhibiting synthesis of T3, T4 as well as inhibiting peripheral conversion of T4 to T3. All these are important MCQs. Finally, after finishing anti-thyroid drug, I am preparing one more slide for you. That point is, name some non-thyroidal drug causing hypothyroidism. This is again important MCQ for AIMS examination. That is non-thyroidal drug causing hypothyroidism. I go one by one. There is one drug going to inhibit release of T3, T4 from the follicle. Imagine it's a thyroid follicle. Imagine it's a blood vessel. So question is, there's one drug going to inhibit release of T3, T4 from the follicle. That drug is lithium. So lithium is a drug for bipolar disorder prophylaxis. That drug may cause hypothyroidism. Now the question is, one of the side effects of lithium is causing hypothyroidism. That is because of inhibiting release of T3, T4 from the follicle. And then second MC question, there are some anti-arrhythmic drug inhibiting conversion of T4 to T3 in the peripheral circulation. What are they? That is amiodarone and propranolol. Remember, amiodarone, a class 3 anti-arrhythmic agent. Propranolol, a beta blocker, comes under class 2. So, anti-arrhythmic drug able to control hyperthyroidism, that too by inhibiting conversion of T4 to T3, mean think of amiodarone and propranolol. The third MC question, there are some anti-TB drug causing hypothyroidism. Who are they? For example, ethionamide and one more drug called PAS. PAS means para-aminosalicylate. Both ethionamide and PAS are second line drug for TB. These drugs going to cause inhibition of synthesis of T3, T4. By inhibiting synthesis of T3, T4, these drugs may cause hypothyroidism. Remember, among these two drugs, ethionamide having more chance of causing hypothyroidism. The reason is ethionamide having chemical structure similar to methimazole, carbimazole. That means thioamide-like structure, thereby inhibiting synthesis of T3, T4. Finally, one more important question. We have one anti-hypertensive drug called as sodium nitroprusside. Sodium nitroprusside containing cyanide. Cyanide. I already explained. Cyanide in the body may become thiocyanate. The thiocyanate may cause inhibition of uptake of iodine. By inhibiting uptake of iodine, they causes inhibition of synthesis of T3, T4, thereby causing hypothyroidism. That means you should know there are some non-thyroidal drug causing hypothyroidism. What are they and how they causing hypothyroidism? All are important point. That finishes some important aspects of anti-thyroid drug. Read well.